First of all, thank you for the kind introduction, and I'm very happy to share with you some of the work we have conducted over the last years in the domain of digital phenotyping. My first question is my PowerPoint clear, or do you see other issues on it? Hugo?
No, it goes well, yes.
Okay, thank you so much. Now, we have worked in the domain of digital mental health interventions over the past 20 years, already more than 2 decades. And the first question which comes to our mind, of course, why would we ever have entered the domain of digital mental health? Well, there is a very important reason for this, because albeit 40 years of evidence-based availability of psychotherapeutic interventions for disorders or common mental disorders like depression and anxiety. We have evidence-based interventions, but only around 30 to 50% of patients are in remission, so really decrease their symptomology after their first treatment. So we have a really high percentage still of relapse. Not everyone has access, and one of the main questions we are still struggling to answer is whether we can predict which treatment would benefit which type of patients, and whether we can also predict progress through treatment. So while we have reached out and while we have a sound evidence-based, we do not know which intervention benefits which type of patients best. And of course, not all of us have access to psychotherapeutic treatment for many various reasons. Now, if we divide the time that we have been working within this domain, we can see that over the last 20 years, we started out with platform development, feasibility and assessment of the clinical and cost effectiveness of psychotherapeutic interventions, especially cognitive behavioral therapy, and that evidence for that type of questions in terms of feasibility and clinical and cost effectiveness, the evidence is getting more and more robust. But again, as what I've said at the start, we still do not know for whom which type of treatment works the best. So we have seen a wave in our research efforts from this type of clinical and cost effectiveness study in the traditional way to see if we can come up with patient-centered, personalized prediction models for psychotherapy regarding diagnostic monitoring, prevention and treatment, and if we are able to improve that domain by the clear use of artificial intelligence and algorithm developments. So that's where we are moving towards now. Hugo has introduced me very kindly. Here you see in some, because the first project I did actually was with you, Hugo, back in 2010, where we already started to think about prediction and modeling and platform development. We have done that in a number of EU projects and also in national Dutch projects. We have done scalability studies, but now we are moving, as said, in that domain of personalized prediction modeling for digital interventions, guided, unguided, and also blended treatments. And one very important role in our domain has played or has been induced by the applicability and accessibility and high penetration rate of mobile phones, smartphones, and all type of other wearables. So this has given us not only an opportunity to communicate in different manners, but also to provide digital interventions, not only over the web, but also through mobile applications. And slowly, by means of what we call ecological momentary assessment, we are able to look into the dynamics of, for example, how a depression evolves on a personalized trajectory in real life or in the natural habitat of individuals and patients. And that comes along, that is a kind of possibility to study and to analyze along our change in paradigm, what actually a depression or an anxiety is as a fixed construct, but much more look at, oh, sorry, that is my dog. It's night in the Netherlands, so they are they look out for strangers. But anyhow, this whole new way of thinking about the symptomology for patients with a depression are very heterogeneous. So we are not looking at fixed constructs, but at the symptoms which may underlie a depression or anxiety disorders and which maybe differ for different type of patients. Now, as said, we focus much more on digital phenotyping, and I have summarized here for you. If we look at a phenotype, we can say, okay, that are the observable patterns of behavior and characteristics of an individual, and your phenotype is made up by genetics, the environment, their interaction and social influence. And nowadays, over the last years, we also look at extended phenotypes, which we call digital phenotypes. Here you see an example of a phenotype. This is a young Moroccan woman who has obtained a skin disease over the last 3 years. As you can see, at the wrinkles on her face, and unfortunately she lives in a country where the sun is shining a lot, in Morocco, so her environment has also speed up her skin disease. The good news of this woman is that she has taken advantage of her phenotype, because she has become a very famous international model. Now, when we look at digital phenotyping, we are using a lot the smartphone in order to both actively and passively measure all kinds of variables ranging from behavior, cognition, exercise, movements, mobility. And instead of doing that retrospectively by standardized questionnaires, people are able to measure that either by their smartphone or by their wearables in their natural habitat. And so we can explore a huge variety of variables which might be exemplaric for changes in mood, for example. So the idea is that with this kind of digital phenotype data, that we can make improvements in the prediction of diagnostics, monitoring, treatment progress and treatment outcome. And in a way, it will enable us to explore better the dynamics of, for example, depression and anxiety disorders. And they, in fact, give us an objective quantified marker in addition to already other data sets or ways of examining, like retrospective questionnaires, clinical interview, the observational gaze of the therapist, and physical exams. And in addition, they can also enrich other type of objective markers based, for example, on genetics, biological markers, or neuroimaging. And what our idea is, but again, we are not there yet, is that it will enable us to integrate all this type of different data sets with very sophisticated machine learning techniques in order to able to predict better which treatment fits someone better, or for example, who is prone to treatment dropout, or even if you progress in a very good way, that you can change your treatment strategy or maybe stop treatment. So that is all kind of this type of developments can lead to decision support tools for the clinicians, but also to self-management tools for patients. Now here again, you see a kind of summary of the digital phenotyping, and there are two different distinctions. That is, you can look out for a digital phenotype as a user of digital communication channels with a specific individualized pattern, or you can actually make actively involved in digital phenotyping typing, so that you look at certain type of proxy measures, which can all be indicative of, for example, cognitive decline, what is now being assessed by assessing the speed of your keyboard attachment, or for example by a change in your communication patterns, which can indicate a withdrawal of social activity, and which can be a proxy of an upcoming depression. Hugo, have I 2 more minutes? Because I actually, then I show 2 small studies and give some points for the discussion, which maybe be at the end of this presentation we can then explore. As said, this domain is really in its infancy, but more and more studies are coming and are being published. And one small studies which we have conducted was based on the research question whether we could predict mood from passive smartphone data with sophisticated machine learning techniques. We had 27 healthy students in our sample. We assessed their passive smartphone data use, so not the content, but actually whether they, which type of communication channels they applied. We assessed their number of steps they made in terms of activity assessment, and we compared that type of data with active daily measures by the smartphone, so that is not passive but active, and asked ourselves the question, can we predict mood based on this passive data gathering? Now here you see some of the results. We were indeed able to predict changes of mood by this passive data collection with an accuracy rate between 55 and 76%. It was a very small study, and certainly it needs to be replicated, but it was for us in 2016 a first indication of entering this new domain. We also did a kind of similar study, but then we assessed both active and passive data as gathered by smartphone use as a component of a large-scale European study. We applied data from 5 countries. This is a paper of 2018, and what we actually saw that indeed we can predict mood on the basis of active data gathering. We also added to the model passive data like adherence rates and usage data, but it actually did not perform our prediction accuracy. Now I have some other examples, but Hugo, given that I have brief time, we also are now entering the domain of natural language processing algorithm development, because we wanted to close the gap between guided and unguided interventions. I can come back into the discussion, but what I really would like to give for the discussion is that if we overlook the field now, as said, it's still in its infancy, but the number of studies are growing rapidly. And I think from a technological and algorithm perspective, this field will evolve very fast, maybe much faster than we think. But what the main issues at stake is, how do we implement and interpret this type of developments as decision or self-management tool in routine care? And I think those questions like the external validation, the trust people should have in this type of algorithms as support to whether you are a patient or a therapist. There is the question of health literacy and privacy. So I really think we should follow, I think we cannot stop the train, but we should really follow also as psychologists and psychiatrists very clearly these type of developments, paying attention to this type of very important issues. Otherwise, those type of algorithm development can be maybe do more harm than good. And I want to give you the following 2 papers, if it's both an a pre for this type of development and a critical appraisal by Jan de Vos, I would highly recommend. And recently 2 papers, overview papers, systematic review papers by Checkroot and Avius van Doorn have been published in October. And if this domain is of interest to you, I can highly recommend this type of papers.